Well, obviously, at the time that we designed the study, we have a long discussion with one of the founders, with Pfizer, about what should be the size of the study in order to provide sufficient evidence that a Palbociclib challenge could play a major role. Indeed, at that time, we didn't know exactly how these drugs work, but we have the exciting database on the first line and second line setting with the different CDK4/6 inhibitor and these amazing benefits in terms of PFS. So the question was if the CDK4 inhibitors could work in a similar way than we observed that anti-HER2 therapies work in the HER2 metastatic disease, in which Rechallenge has become a standard of care. So the design of the study was very specific and very different in one concept shift to the other studies that have been run about rechallenging CDK4/6 inhibitors, because here we specifically looked for maintaining the same CDK4/6 inhibitor. That was the major difference with the old study and the other ones. And it's true that we expected to have, initially the design of the study was designed in order to observe a benefit that could be in the range of a hazard ratio of 4.7. Okay, so not as significant as for the first line CDK4/6, but sufficient enough to provide a clinical benefit and not just a statistically significant one. Obviously, the final results are very clear, although we observe a very small signal, nothing really relevant in terms of clinical benefit. So clearly showing that rechallenging the same CDK4/6 inhibitor, at least related to Palbociclib, has no clinical interest. Okay, it's sure that there are some patients that achieve a benefit. But finally, when you analyze even the patients in the Palbo maintaining therapy, the number of patients that achieve a significant prolongations in her second line was very limited. Although it was slightly better, superior, when you analyze the number of patients that achieve, I will say it, 6 or 12 months of PFS on this second line was very limited. Particularly, we analyzed the 12 months. But it is true that, I mean, one of the surprising findings is that in this study, we accepted patients coming from letrozole, but also from fulvestrant in the first line, not being resistant to the other chance of endocrine therapy. That was because we designed another study that was the Parsifal, and half of the patients on Parsifal could also be included in this study. So in order to don't lose some opportunities. And there is an interesting signal in the patient that switched from letrozole to fulvestrant, from fulvestrant to letrozole. There we observe some interesting signs. But I think that although that could merit another study, it's quite difficult to design now and to try to answer which are the patients that truly could benefit from maintaining Palbociclib. And I think that honestly, with the great number of the opportunities that we have right now in this second line setting, analyzing mutations like SO1, P3 kinase, and others, as well as other treatments, I think that obviously maintaining Palbociclib for me doesn't seem something reasonable in any scenario, because we have probably better options for all patients in this setting. Obviously, the feeling that clinicians have is that Palbociclib is less potent than Ribo and Abema. At least that was how it looks from the data, the final data related to survival. My thought is that if you want to rechallenge with a CDK4/6 inhibitor, you should change the CDK4/6 inhibitor. That what it doesn't have sense is to maintain the same. I mean, maintain as well as postMONARCH, the vast majority of patients came from a different CDK4/6 inhibitor. In the MAINTAIN, about 86% of patients have been pretreated with palbociclib. Very few came from ribo to ribo. And that's the same for postMONARCH. Very few patients have received prior abemaciclib. So I think that there are some arguments to continue on a CDK4/6 inhibitor, but the reasonable thing is to change the CDK4/6 inhibitor. That will be my message. It is true that we don't have clear data about ribo after ribo or abema after abema, but what it makes sense is that if you want to do something, change the CDK4/6 inhibitor. I think that is essential. I mean, I cannot imagine how in the future we will be able to decide just by clinical arguments the second-line setting, because the benefit that we are observing with the new PI3 kinase inhibitors as well as with the SR1 inhibitors, I think is amazing. And patients that will not be tested for at least these two mutations, I don't talk about other ones like AKT or P10 or even in the future mTOR, but I think that it becomes crucial when you have to take the decision about that second line among patients that you consider that continues to have an endocrine opportunity to check for the best one. Because those patients that will progress very quickly to a second line endocrine therapy, if not selected by biomarkers, will be certainly driven directly to chemotherapy. So it's important to target very well, which is the second line treatment, because that opens the chances also not just for this second line, but also perhaps opportunities for a third line of endocrine therapy before being moved to chemo. So I think that I cannot imagine right now in my clinic, even in countries like mine, where we have some limitations to have access to some of the drugs that are in the market in other countries, to take the decision without any biomarker. Because it is true that the clinical benefit to the CDK4/6 inhibitors is a very strong prognostic factor and probably also predictor for more endocrine sensitivity. But the one that really targets the optimal endocrine treatment, it should be driven by biomarkers. I mean, my feeling is second line will have very good new opportunities in the very, very next future with the new drugs, okay? Both SERM, SERD, SR1 inhibitors, as well as by the PI3 kinase pathway. But again, it's true that even the most sensitive patients have limited benefit from these treatments. Okay, so the median PFS in this population, second line, perhaps we will be able to improve up to 1 year. We are now in the 7, 8, 9 months. So I think that in the future, the major efforts will be related to how we can increase the sensitivity in the first line. And I think the inavolisib study, INAVO 120, has shown very nicely that we have room in the first line setting to continue to improve the benefits of CDK4/6 inhibitors. There are new CDK4 inhibitors, very attractive, that seems much more potent than the CDK4/6 inhibitor, but I think that in the future, triplets will become a very standard approach for patients with mutations, with PI3 kinase pathway. And I think that that will be the way, particularly to identify the patients with less sensitivity criteria, the ones that have endocrine chances, but at the same time, you are not so sure that they will have a very long journey on endocrine therapy. Those are the ones for which we will have to focus on the first line, trying to implement and to improve the benefit, exhausting everything, but all in the first line. I think that that's where we will see the major gains.